Hello and welcome to my channel. This is a new course that I'm starting called the MBBS FlashDash, which is mainly aimed at final year medical students who need a quick revision before their finals. In this video, I will be continuing part 3 of the Cardiology Series. Do check out the links below in the description if you want written notes from my website and also flashcards which I have uploaded on Pinterest. So let's get started. In this video, we will be covering axis deviation, heart block, atrial fibrillation, atrial flutter, ventricular tachycardia, paroxysmal supraventricular tachycardia or otherwise known as narrow complex SVT, Torsades De Pointes, ventricular fibrillation, left bundle branch block, hypokalemia, and hyperkalemia. Okay, the first one is axis deviation. The normal axis is negative 30 degrees to positive 90 degrees over here. This is the normal range. And then you have the left axis deviation. That is from negative 30 to negative 90 degrees. And the right axis deviation, which is from positive 90 to positive 150 degrees. Followed by the right superior axis deviation, which is from positive 150 degrees to positive 270 degrees. You know the normal axis, the left axis deviation, right axis deviation, right superior axis deviation, that's, really rare to come across unless the person usually has a congenital heart defect. So how would you determine the axis deviation? You need to see lead 1 and lead 2. So when you see an ECG, hold the ECG strip. Your left hand obviously holds the left side of the ECG strip, and the right hand obviously holds the right side of the ECG strip. All right. So take the thumb of your left hand as lead 1, and take the thumb of your right hand as lead 2. Okay, so if you're not holding a paper, grab a paper now and pretend it's an ECG strip. Your left thumb represents lead 1 and your right thumb represents lead 2. If both of it is pointing up, it's a normal axis. The axis is normal, there's no deviation. If your left thumb is up and your right thumb is down, you always follow the thumb pointing up. It's a left axis deviation. If your right thumb is up and your left thumb is down, remember, follow the thumb that is pointing up. So it's a right axis deviation. So again, to determine the axis deviation, just look at lead 1 and lead 2. So I know it can be really confusing. It's okay, pause the video, go through again slowly and practice it. Always follow the thumb that is pointing upwards. What is the normal axis, left axis deviation, right axis deviation. So what are the causes? Here are a few causes. So for left axis deviation, it's usually due to an inferior MI, an inferior myocardial infarction, left ventricular hypertrophy, left anterior fascicular block or a hemiblock, an obese person, or Wolff-Parkinson-White syndrome. So in Wolff-Parkinson-White syndrome, you will notice delta wave on the ECG. Right axis deviation, it's caused by lateral myocardial infarction, right ventricular hypertrophy, left posterior fascicular block, a hemiblock. So left axis deviation, it's left anterior, and right axis would be left posterior. Teen tall children, as opposed to the other one, which is in obese person or obese people, chronic lung disease, and pulmonary embolism. This is followed by the extremer right axis deviation, the other one. So it is usually due to congenital heart disease, so it has been going on for some time, or the patient may have a left ventricular aneurysm, which is a complication of a myocardial infarction. I actually went through a little bit about the left ventricular aneurysm. Do check out the first video. It's actually on part 1 of cardiology, so do check it out if you want to know more or if you haven't gone through it yet. Next is the heart blocks. Okay, so for heart blocks, you have 3 types: first degree, second degree, and third degree. In second degree, you have 2 subtypes called Mobitz type 1 and Mobitz type 2. Okay, the important thing to know about heart block is when there is a heart block, bradycardia occurs, irrespective of the type of degree. And usually when a patient presents with bradycardia, the first thing you want to do is actually give atropine. But that is if you can't actually determine what type of degree. But over here you can. And if you have determined the type of degree of heart block, there is the treatment is actually different. So the first one, first degree heart block. In first degree heart block, there is prolonged PR interval. So the normal PR interval is actually about 3 to 5 small squares. So in the case of first degree heart block, it is prolonged. So it's more than 5 small squares. So when you see an ECG, look at the PR interval first. Is it prolonged? Is it more than 5? Is it longer than usual? Then you compare it with the other PR interval. Okay? So in first degree heart blocks, it's just prolonged. Maybe 6 boxes, maybe 7. But it's the same for all the PR intervals on that ECG strip. As you can see here, it's actually the same. It's just longer. In this case, this is a first degree heart block and degree heart block. In second degree heart block, as I mentioned earlier, there are 2 subtypes. There are Mobitz type 1 and Mobitz type 2. So in Mobitz type 1, remember in first degree heart block, we were talking about the PR interval? Okay, in Mobitz type 1, the PR interval lengthens over time. Basically, it just keeps getting longer and longer. The next one is longer than the other one. The next one is longer than the other one until finally a beat is missed. Okay? So when they say a beat is missed, they're basically talking about the P wave is present here. P wave is present, but there's absent QRS. So it's just, slowing down, and eventually nothing. In this case, you would administer atropine if there's hypotension or bradycardia. Now there's Mobitz type 2. In Mobitz type 2, you would denote that the PR interval is constant. But suddenly there's a drop beat. Like here, you see 1, 2, beat drop, nothing, and normal again. It can be confusing with this, the first one and the second one. But remember, in the first one, the PR interval just gets longer over time. Basically, the heart is just slowing down. But in Mobitz type 2, the PR interval is the same. It's just suddenly followed by a beat drop. In this case, the patient requires a pacemaker. Now in the third complete heart block, third degree heart block, the atria and ventricles contract independently. There are no association between P wave and QRS complex, and it's most commonly caused by myocardial infarction or Lyme disease. The treatment would be, the immediate treatment would be atropine 500 microgram IV. And the definitive treatment would be a pacemaker. So in the case of heart blocks, you are required to give a pacemaker. The definitive treatment would be a pacemaker for Mobitz type 2 and third degree heart block. Remember that. But essentially, in the case of bradycardia, because heart block, the patient will usually be bradycardic. They will have bradycardia. In that case, you need to give atropine first. I know I didn't include the ECG for the complete heart block, but basically in the third degree heart block, it's not as uniform as this, you see. Basically, everything is kind of just neat. But in third degree heart block, it's all haywire. Atrial fibrillation. So in atrial fibrillation, there are irregular PR intervals and no discrete P waves. The pulse rate would be irregularly irregular. Now, how do you treat this patient? First of all, is the patient stable or unstable? In the case of an unstable patient, you would proceed with electrical cardioversion. Electrical cardioversion, not a defibrillation, because the patient still has a pulse. If the patient doesn't have a pulse, then you do a defibrillation. But in the case of an atrial fibrillation, the patient has a pulse. It's just that it's irregularly irregular. Now that's if the patient is unstable, hemodynamically unstable, of course. If the patient is stable, hemodynamically stable, the first line would be beta blockers because you want to control the rate. Patient with atrial fibrillation, the heart is beating really, really fast. They have high heart rate, increased heart rate. So you would give beta blockers to basically control the rhythm, slow down the heart. But you do not administer beta blockers, of course, in asthmatic patient. In asthmatic patient, you would give calcium channel blockers, so like diltiazem or verapamil. Now, to control the rhythm, you can administer amiodarone or flecainide. This is followed by anticoagulation, such as warfarin or NOAC, but that depends on the CHA2DS2-VASc score. An important complication to remember about atrial fibrillation is that patient can develop stroke. That's why you need to administer anticoagulation and you need to get the heart rate under control. So this is the CHA2DS2-VASc score, and it's good to remember. Okay, so everything gives a score of 1. But if you notice how the name was actually written, it's CHA2DS2. So the ones with 2 beside, if they fulfill that requirement, you give a score of 2. Otherwise, the rest you give a score of 1. So C for congestive heart failure, H for hypertension, A2 for age more than or equal to 75 years. So for that, you give 2 points. D for diabetes mellitus, 1 point. S2, prior stroke, transient ischemic attack, thromboembolism, 2 points. V, vascular disease, 1 point. A, age 65 to 74 years, 1 point. So notice here they mentioned age twice. So it depends. If it's more than or equal to 75 years, you give 2 points. If it's 65 to 74, only 1 point. SC, sex category. So if it's a female, 1 point. After you have assessed them, depending all patients with score of equal to or more than 2, and men who score equal to or more than 1, you start administering warfarin or DOAC. Okay, so what is warfarin what is NOAC and what is DOAC? It's actually the same. They are oral anticoagulants. NOAC stands for new oral anticoagulants and DOAC stands for direct oral anticoagulants. They're the same drugs actually, apixaban, rivaroxaban, dabigatran. If you were to look in the ECG, atrial fibrillation will present with fibrinolytic waves. You can see over here, it's like they're not steady. It's like there's tremors on the ECG. Now let's compare with atrial flutter, because these two, you can put them side by side. Okay, so in atrial flutter, there are identical and rapid back-to-back P waves. And the appearance on the ECG would be a sawtooth appearance. Okay, so if you can see over here, it's like there's fins, right? It's like a sawtooth. It looks rather sharp. It's more defined. It's just like P waves back to back. Okay, it's like they're flying, they're fluttering. If you compare with atrial fibrillation, it's like they're just vibrating, there's tremors. But over here, flutter, it's like they want to fly and take off. That's how I remember. So depending on how you want to remember it, this is how atrial flutter looks like. The treatment is same as atrial fibrillation. The patient is unstable, you proceed with electrical cardioversion. Hemodynamically unstable because the patient has a pulse. In atrial flutter, the patient has a pulse. And if the patient is hemodynamically stable, of course, first line would be beta blockers. You're going to get a heart rate under control. Is the patient asthmatic or not? If the patient is asthmatic, use calcium channel blockers, diltiazem or verapamil, followed by rhythm control, amiodarone or flecainide, and anticoagulation if they fulfill the CHA2DS2-VASc score. Next is ventricular tachycardia. Ventricular tachycardia are broad complex tachycardia originating from a ventricular ectopic focus. And it's important to remember that it is the most important shockable arrhythmia because they can develop into ventricular fibrillation. In ventricular tachycardia, the patient still has a pulse, but in ventricular fibrillation, the patient do not have a pulse. This is how I remember it. I know it's really bad, but you gotta do what you gotta do. I mean, to pass the exams, right? It's obviously most of us, we study medicine because we want to study, but we are near exam and you know you can't grasp the topic. You just gotta do what you gotta do to pull through. So for ventricular tachycardia, you will notice long waves like this going up, going down, going up, going down, going up, going down. Okay? In ventricular fibrillation, everything is just gone. I call this gone case. Okay? So before I enter ventricular fibrillation, take a look at the ECG. So this is ventricular fibrillation, and this is ventricular tachycardia. So I just remember like ventricular tachycardia, T, you know, they're tall, like this, going up, down, tall waves. Fibrillation, they're like, you know, shaking. Okay, so ventricular fibrillation. Ventricular fibrillation, it is completely disordered ventricular electrical activity. There are no identifiable QRS complexes because, yeah, you can't see anything. Like, what is this? And the patient usually doesn't have a pulse. In this case, immediate defibrillation to bring back sinus rhythm. Remember, defibrillation. When do you do a DC cardioversion? If the patient first has a pulse, second is hemodynamically unstable. When do you do defibrillation? One, patient doesn't have a pulse. The end, patient doesn't have a pulse. Do a defibrillation to bring them back. Now we're going to talk about narrow complex SVT. It usually occurs in young patients and they present with palpitations, lightheadedness. It's usually recurrent. And like I said, in young patients, again, are they hemodynamically stable or hemodynamically unstable? So if they're hemodynamically stable, you do a Valsalva maneuver. Basically, you ask them to plug their nose and blow out hard. And we usually do this to like unblock our ear when we are in a place that's really high. You know, our ears tend to get like blocked for a while and we have reduced hearing. So that's Valsalva maneuver, followed by carotid massage. And if they are still like this, then you give adenosine. First 6 milligram IV bolus. No improvement, 12 milligram IV bolus. No improvement, 12 milligram IV bolus. I remember it as 6-12-12, adenosine 6-12-12. And still if no improvement, you can proceed with DC cardioversion. If the patient is already hemodynamically unstable, you don't have to ask them to do the Valsalva maneuver and the carotid massage. You might as well just, jump in and shock them. So if the patient is unstable, you do a electrical cardioversion. All right, now it's Torsades De Pointes. Earlier was narrow complex, okay? Now we're going to talk about broad complex. Basically, for Torsades De Pointes, it is like this. It is as if they are coming. You can see like an infinity shape on the ECG. So it is a type of polymorphic ventricular tachycardia where the QRS complex appears to be twisting around the base in ECG. So it's over here. And the cause is usually by QT prolongation. But a patient with Torsades De Pointes, they may degenerate into ventricular fibrillation. So that's very dangerous. In this case, how do you treat them? It's with IV magnesium sulfate. However, if the patient should progress to ventricular fibrillation, then do not give IV magnesium sulfate. Of course, just proceed with defibrillation. Alright, so you notice that for Torsades De Pointes, the management is actually quite different. Like for the others, it's just straightforward. Patient is stable. You start with carotid massage, Valsalva maneuver, amiodarone, finally DC cardioversion. Patient is unstable, DC cardioversion. Patient doesn't have a pulse defibrillation. Patient has bradycardia atropine. Depending on the type of heart block, then you would opt for the definitive treatment, which is to place a pacemaker. But in this case, this is literally the only one with which you treat with IV magnesium sulfate. Of course, there are a few other diseases that you can treat with IV magnesium sulfate. However, I won't dive into it. I won't dive into it in this particular course, cardiology, because you can it will be covered later on. All right, so comparisons. I know there are actually others that you should learn, but for exams, these are actually complete enough. As well as the heart blocks, don't forget, go through the heart blocks again and go through this. Learn how to differentiate between fibrillation and flutter. Flutter, it has a sawtooth appearance. It's like they're flying to take off. Back-to-back P waves. Fibrillation, it's like they're having a tremor, okay? Ventricular tachycardia, T for tall, so it's like this. And ventricular fibrillation, it's just gone. They're dancing all over. Narrow complex SVT, it's like this. It's all near each other. And Torsades De Pointes, it's broad complex. This is narrow complex, this is broad complex, so it's big like this. And there's twisting, looks like an infinity. And they can progress to ventricular fibrillation. Rule of thumb for cardioversion and defibrillation. So I know I've gone through this many times, but I would like to re-emphasize again. If the patient has a pulse, first of all, you need to check, does the patient have a pulse? Yes or no? They have a pulse. Are they hemodynamically stable? If they are, you give amiodarone. Of course, you start with Valsalva maneuver and carotid massage, amiodarone 6-12-12, IV bolus, and followed by DC cardioversion if the patient doesn't improve. But if the patient is hemodynamically unstable to begin with, you proceed with a DC cardioversion. If the patient doesn't have a pulse, straight away proceed with immediate defibrillation. It's important to know the in-hospital cardiac arrest algorithm as well. So if a patient presents with no signs of life, usually it's no pulse. That's the first thing you would detect. They're not breathing, not responding. The first thing you would do is code blue. So you would call for help, ring the emergency bell, call the resuscitation team. Then you start with CPR, okay? 30 compressions to 2 breaths, followed by defibrillation, and finally when the resuscitation team arrives, you proceed with ALS. It's good to know for MCQs. I remember it came out for my exam, but otherwise it's just general. I mean, if you like to watch those medical TV shows, I used to watch them a lot back when I was studying. Yeah, it's the same procedure anyway. Left bundle branch block. So with chest pain, a new left bundle branch block is indicative of a myocardial infarction. It is an indication for thrombolysis or percutaneous coronary intervention. How do you decide between thrombolysis and PCI? It's the presentation since the onset of symptoms. So if it's less than 12 hours, then you proceed with a PCI. If it's more than 12 hours, then you proceed with thrombolysis. So I actually talk about this in the acute coronary syndrome in part 1 of the cardiology. So do check out my first video on that. So in the ECG, you will notice a notch, an M shape, broad complex QRS. So it's here, the red ones. M shape, it's like M. In leads 1, AVL, and V6. In lead V1, it's opposed, okay, opposite. So that's this one, this color, deep inverted negative QRS, or in other words, it's the W sign, okay. So left M. In V1, it's the other way around. Hypokalemia and hyperkalemia. So hypokalemia basically means lack of potassium, but by how much? Okay, hypokalemia is when the serum potassium level is less than 3.5 millimoles per liter. They may present with muscle weakness and cramps, as well as U wave on the ECG. Okay, this is U wave. So what is a U wave? Basically, after the T wave, there is another wave. Just basically look at the T wave. If there's another wave, that's a U wave. So that is hypokalemia. Of course, sometimes they may not have U wave. They may have just broad, flat T waves, or even ST depression or QT prolongation. So the most common reason would be due to diuretics, thiazide-like diuretics and loop diuretics. The treatment would be oral or IV potassium chloride, because your lack of potassium anyway, so you need to give them potassium, followed by stopping and treating the cause. Okay, so take a look at this. Sometimes they may have ST depression, or the T wave may start to flatten. After the T wave, there is another wave, okay? All right, that's the U wave. Now let's go on to hyperkalemia. There's too much potassium. Wow. Okay, hyperkalemia is when the serum potassium level is more than 5.5 millimoles per liter. As opposed to hypokalemia, on the ECG, there are tall tented T waves. So you see, the T wave over here is like, they're not that crazy, but you look at the T wave in hyperkalemia, like they overshoot the R wave, like wow. That's just weird. And yeah, they're taller, they're like competing with the other one, like, no, I want to be taller. I'm just kidding. All right, so there's tall tented T wave. So you look at the T wave, is it higher than the R wave? Loss of P wave, as you can see here, there are no P waves. Okay, and widened QRS complex. Initial line would be to give calcium chloride or calcium gluconate or calcium carbonate. Why? You want to protect the heart first. You want to prevent cardiac arrhythmias. This is followed by IV insulin infusion, followed by dextrose. This is to reduce the potassium concentration. There are a few causes that's good to know. Okay, it's important to know actually. For hypokalemia, like I said, the most common cause would be loop diuretics and thiazide-like diuretics. But it can also be caused by vomiting and diarrhea, villus adenoma, renal tubular failure, Cushing syndrome, and Conn's disease. Whereas for hyperkalemia, it can be caused by ACE inhibitors, ARBs, angiotensin receptor blockers, potassium-sparing diuretics, chronic kidney disease or acute renal failure, Addison's disease, the primary adrenal insufficiency, or congenital adrenal hyperplasia. If you've reached this part of the video, thank you so much for watching. Do hit the subscribe button and press the notification bell so you don't miss out on any new videos. I post videos weekly. See you in the next one. Stay tuned.